right, June. Guess we're here. Welcome to the Psych Guys Remote Edition.
Welcome back, everybody. And for those of you guys checking us out for the very first time, I'm Dr. Joon Chun. That's my co-host, Dr. Logan Noone.
Yes,
We're
sir.
psych residents.
Psych residents, second year, soon to be third year. So what that means, listeners, is we're roughly halfway through our psych residency. We both graduated medical school 2 years ago. We're going to be reviewing interesting case me and June have, I don't know, how many cases have we seen probably similar to this in our 2 years here? At least hundreds. Not thousands yet, I would say, but would you agree hundreds?
Too many.
Right.
At least the way our program is structured, we spent a significant amount of time working emergency psychiatry, covering our local emergency department here. And that's exactly the type of case we're talking about today. The case that we're going to be covering has to do with somebody who presented with suicidal ideations and unfortunately ended up completing their suicide.
Right. Yeah, isn't that always kind of weird, the terms that a psychiatrist use when it comes to this stuff like completed suicide, attempted suicide, arguably sometimes you'll even hear like successful suicide attempt, even though that's kind of like an oxymoron in its own right. But, so listeners, what we're going to do is we are going to be reading through this case kind of together. All specific healthcare or health information has been removed. So we will be saying like Miss S, Mr. D, Dr. S. This is not actually the real names. We don't even know when and where this exactly happened. And so, yeah, let's just dive right into it. So this case involves...
So hold on, Logan. Let's give a little bit of background information. So this case that we're pulling is from MedMal Reviewer. I believe this guy has a Substack that's very popular. And this guy, he reviews a lot of different, essentially medical lawsuits, right? So this is a case that, took place and the information was pulled as part of a civil lawsuit against the ED physician and also the social worker that was involved in the case. So that's kind of the background of the story, and that will make more sense, just by the structure of how things are written. So there you go. That's the background information. Let's get into it, Logan.
All right. So this is a 24-year-old woman. We're going to refer to her as Mrs. C. Miss C, actually. She was in a vehicle with her boyfriend, Mr. D, who broke up with her while they were driving. Not always the best way to break up with someone. Of note, she was intoxicated, made suicidal statements, and tried to jump out of the moving vehicle. Mr. D stopped the car, called 911, and Miss S was taken to a nearby ED. I think what's relevant kind of to this story is they don't actually tell us how intoxicated. Was she just intoxicated with alcohol? Were there other drugs involved? And how severely intoxicated was she? Was she someone who we would consider like blackout drunk? Or was this only, a few drinks in?
Right. And that's very relevant information because obviously people make crazy statements when they're under the influence of alcohol or any other substance for the matter of fact. So if it turns out that Miss C was severely intoxicated, we wouldn't necessarily be able to hold her to any of the statements that she made while she was under the influence of alcohol. So great point, Logan. We don't know how intoxicated she was, but we do know that she was intoxicated. I guess when we have cases like this, we kind of refer to it as, is the patient clinically intoxicated, right? Is the patient able to hold a conversation? Are they slurring their words? And we also look at their blood alcohol level. Generally, the cutoff that we use here is if it's above 100, if the blood alcohol level is 100, we consider them clinically not sober, and we give them a few hours to kind of, let the alcohol leave their body so that whatever statements that we get from them in the interview that we do with them does have standing value.
And just for the listeners, like we said, blood alcohol level of 100. Is the units, maybe you can double check on this, is the units milligrams per deciliter? I'm actually not sure. But I think what was more common, what people can know is like the legal driving limit is 0.08. And in the medical world, that's actually 80 for us. So for us, when someone's at 0.1, so still actually not capable of driving a car legally, then they could actually have a conversation with someone from the mental health team. But, in this expert case that we're reviewing, we actually don't have any idea how intoxicated this person was. Was there other drugs involved? I imagine this person did have to meet a certain threshold because they eventually talked to a social worker. I imagine they followed proper protocol, but maybe they didn't. Maybe that was actually part of the fault of this case too. So at the ED, did you get that milligram per deciliter, that unit?
No, I didn't. But I think what you said was a pretty good explanation. The units are kind of different, but like 0.8 would be equivalent to 80.
Okay. So at the ED, they were seen by EM physician. We'll call this person Dr. S. The patient was medically cleared, and that means the EM physician, the emergency room physician, medically cleared them, but didn't psychiatrically clear them, and then had them evaluated by a member of the psychiatry team. At that time, the patient stated she was no longer suicidal, contracted for safety, and was discharged with referral for outpatient resources. So I'd like to pause here, Joon, because I want to talk about contracting for safety. What does that mean to you? And let's explain that to the listeners.
I also have that highlighted in my notes. So that's one of the interesting things that we use, right? Because so what is contracting for safety? Contracting for safety is essentially patient is signing a little form. It's not a legal document, but it's just a form that they fill out saying that under circumstances where, for example, they have suicidal ideation, they're gonna do X, Y, and Z. So generally speaking, these forms have, their protective factors. So for example, a very common thing would be if I start to develop these thoughts, I will reach out to my mother, and B, if that fails, I will call my therapist, and C, if that fails, I promise that I will come to the emergency department. So I think of it as essentially a checklist, and how-to guide for whenever you start to have these kind of thoughts pop into your head. It's like a guide for how to act.
Right. And, at least in the literature that I've seen, sadly, it doesn't really necessarily lead to clinically improved outcomes. I think it's in a way kind of good old CYA medicine. What I mean by that is cover your ass medicine. We live in a very litigious society, right? And it's like, oh yeah, well, this patient signed this contract saying that they would call somebody when they felt suicidal. It's like, yeah, but is that actually deferring them from actually acting on those urges and those bad thoughts? And I of course have done contracts for safety. It's something I'm obligated to do in this role. Do I think it's actually having a significant, true, amazing impact on this person's lowering their suicide risk? I don't always strongly feel that way.
And it's pretty common knowledge that there's not much evidence for contracting for safety. I feel like at this point it's something that clinicians do because to a certain degree we feel like there's nothing else we can do. Obviously, a patient comes in with suicidal ideations. What can you really do in that setting, right? Our role in the ED, in the emergency department setting, when we come across patients like this, is mainly to decide disposition. And by that, I mean, are we going to hold them here in the hospital? Sometimes that means on a voluntary basis. Sometimes that can mean on an involuntary basis. Or are we going to discharge them? Are they appropriate for outpatient level of care? So those are the questions that we're trying to answer. And sometimes we feel limited, even frustrated by the lack of techniques that we can use. And, at times we can even feel like we can't do as much as we want for that patient. So Logan, I have some statistics for you. So actually, when we're talking about contracting for safety, a study found that out of people who attempted suicide and now were admitted to an inpatient psychiatric hospital, 65% of those individuals had signed a contract for safety. So those are pretty abysmal numbers, right? 65% of people admitted after a suicide attempt, they had contracted for safety. So we can pretty much look at that and say, hey, there's a very, very, very high chance that contracting for safety does nothing. Furthermore, they did a survey which included 2,000 psychiatrists, and it showed that 40% of these psychiatrists had a patient make a serious or even a successful suicide attempt after contracting for safety. So basically, we can safely say there's been enough data to know that contracting for safety has not been shown to be useful with patients who are psychotic, impulsive, depressed, or agitated. In fact, some evidence even suggests that it may be harmful for people, especially those diagnosed with borderline personality disorder.
Interesting. I mean, yeah, that last part, why harmful for people with borderline personality disorder. I wonder why. I mean, can you offer any theories why that would potentially be harmful for someone with borderline?
Right. So when I read it, I had the exact same reaction as you, Logan, and I gave it some thought. And of course, this is just, an educated guess from having worked with actually a lot of borderline patients by this time. So my working theory is that, when we think about borderline personality disorder, these patients have really, at the core, a really hard time controlling the intensity of their emotions. And a lot of them have pretty low frustration tolerance and very poor impulse control, meaning that they're very apt to make rash kind of actions that can sometimes be very drastic. So what I imagine is when you're somebody with borderline personality disorder and you're in a position where you're starting to have these level of dysphoric feelings that reach the level of suicidal ideations, you kind of think back and you remember the promise that you essentially made your doctors. And I feel like that level of responsibility may even contribute to that feeling of dysphoria, that the feeling that they might let somebody down. And at the core of it, why do patients with borderline personality make impulsive and rash decisions that sometimes take the form of suicide attempts? It's because they're unable to tolerate that intense emotions of dysphoria, right? So that they act out in a way that's going to distract them from that core feeling. So it might be a case where that contracting for safety is adding to that level of commitment that they feel, and having these kind of negative emotions, there's an internal conflict there. And that's more likely to lead them to a place where they're going to act out in a drastic way so that they can take their mind off of the commitment that they made. You think that's reasonable, Logan?
I think that was actually extremely well put, and I'm glad I made you answer that question because I would not have answered that question as well. So,
that's not fair because I thought about it before. That's the only reason.
Right. So the last part of this, after the patient stated she was no longer suicidal, she signed this contract for safety. She was discharged with a referral for outpatient resources. What we don't know is how long was this patient in the ED? How long was she held for observation to see, did she engage in any self-harmful acts? Did she change her attitude about suicidal ideation? Who really knows? But I did want to also pause kind of on this. It seems like a lot of times, especially in our role, we can only really comment, I guess, on New Jersey, but it's, okay, are we admitting this person involuntarily? Are we asking them, hey, do you agree to go into the psych ward? Or are we discharging them home? And we do this all the time, referral for outpatient resources. Now, so there are programs in between, intensive outpatient programs, partial hospitalization programs. Getting someone signed up for those is a lot more challenging than it should be. It seems like a lot of the time, it's like, oh yeah, you can start one of those programs, but it's in 2 weeks. Or you can only do one of those programs immediately after you're discharged from the hospital. It is a horrible system. When I was manic years ago, I remember actually thinking that's what I really wanted, like some kind of acute urgent care intensive outpatient program, but they said, oh, that's not something that you can access right now. Now, just for reference, I'm actually using this program, Babbel, to try to improve my Spanish skills because I'm estoy estúpido en español, right? What's interesting about Babbel, okay, it's a worldwide application. I can sign up for live classes I can look on my phone right now and I could sign up for a live class that starts at 1 a.m. tonight. It's an online class. Because it's online, that teacher is probably sitting somewhere where it's a normal business hour and all over the world, right? Why can't we do something like that similar in America where, let's say that this was at 5 a.m. or whatever. We could discharge them and say, hey, look, there's this suicide ideation course that is starting at 7 a.m. that you can access with your phone in 2 hours from now. We want to discharge and ensure that you're going to log into this course online. I know there's going to be some issues there because, yes, it's across state lines and our medical licensure is really only active in each state. We can only be licensed, You can license in many states, but you get what I'm saying. I wish we could almost implement like that Babel structure into our referrals for outpatient resources. Because I feel like a lot of times we discharge these patients saying, hey, call these numbers. How often do they realistically actually follow through with that referral?
Probably close to zero. I mean, I hope that's not the case.
I don't know about zero, but it's certainly
maybe I'm
not
exaggerating a little bit, but it would pretty much be abysmal. I'm ready to pretty confidently say that.
Yeah.
So I guess what you're talking about is just the overall lack of funding for mental health resources, right? We know from the data that's coming out, especially when we look at self-harm, suicide rates, it's going up for all age groups. But the funding for mental health resources has not really kept up with the demand and the need for increased resources. So it's more of a systemic problem. I wish there was an easy solution. I wish there was a quick solution. And I guess that's a big part of why we're doing a podcast like this, right? We're trying to raise awareness and saying that, hey, there is a need. There's a great need. There's people suffering out there, and we need more funding for resources for mental health.
Right. All right. So let's get further on with this case. So 5 afters after Miss C was discharged, she jumped in front of a vehicle on the interstate and died. Police determined that she died by suicide. Her family filed a lawsuit against the EM physician, his employer, the social worker who did an in-depth psychiatric interview, the police officer who responded to the 911 call, and the ambulance service that transported her to the ED. In particular, the plaintiffs accused the EMS personnel of not communicating the fact that she had tried to jump out of the moving vehicle to the ED physician. All right,
Logan. So let's take a hard pause there. So everything that we covered so far, I see one glaring issue. So I want to take you back to the moment where the patient was seen in the ED by the EM physician after being medically cleared, right? And she kind of said that she was no longer feeling suicidal. She contracted for safety and was discharged with outpatient resources. The thing that bothers me about this case and that immediately stood out to me was, how come no collateral was contacted? Right? We have the patient in front of us, and we get all different types of stories from patients, right? And sometimes you hear a story and you're like, oh, I can't believe the police brought you in for that, or I can't believe your family members felt the need to bring you in for that, right? And if we just stopped their evaluation there, we would discharge a lot of those patients because they're telling coherent, logical stories that make sense. There's a perfect explanation for everything that's reported, and you're just like, oh, okay, that makes sense. I don't know why you're here. But when you call collateral, which means anybody that's really in the know-how of what happened, the situation that took place prior to their arrival to the hospital, Logan, how many times have you been shocked to hear a completely different story?
Right.
Yeah, you talk to somebody and your whole perception of the case changes. And that is, it's almost, I would even say it's almost standard of care, especially when you're discharging somebody.
And that's why
you have to verify their story. Yeah, so I think it's ridiculous that nobody was called, and that alone, I feel like, screams negligence to me in this case.
Right. I agree with that. I simultaneously also sort of disagree with that. What time of day was this called? Because there's been many times in my clinical experience where I've attempted to call collateral, nobody picks up the phone. And I can't always blame them. Sometimes it's 4 a.m. I'm doing these evaluations, right? People don't pick up the phone. Now, I'm not advocating that this patient should have been discharged for that reason. A lot of times what, I've done in my clinical practice is, well, hey, look, I need to get further collateral information. We need to hold this patient longer. And, I kind of want to get more into this later, but, I kind of wonder how much of the business of emergency rooms kind of factored in on this. We as psychiatrists are always pressured, I feel like, to try to make decisions quickly. Emergency rooms make money the more patients they see. So if you're holding a bed, that's one less patient that you can see in that emergency room. You can't bill twice kind of thing. So, kind of the warlords of the economic side of healthcare, I wonder how much that influenced this social worker maybe acting abruptly and making a decision that, arguably wasn't maybe the correct one, right? But I also think it's impossible to really perfectly know the future, right? Because what I think is relevant here too is, in this case, and we can kind of link it in our show notes or whatever, there was two expert psychiatrists, one saying, of course, like you highlighted, the collateral information wasn't called. But there was also some information that was relevant post-discharge that really had nothing to do with that discharge. So additional information came to light about how the patient's mental state changed after she was discharged. The patient's ex-boyfriend reported that there was another disagreement after the discharge that may have precipitated her suicide. Was there further drug use involved or alcohol use involved? Was there, like I was saying earlier, was there further drug use? What actually happened after discharge? Was there another significant fight that occurred that did maybe play a role? And how are psychiatrists or mental health teams necessarily supposed to intervene there? Could this have been handled differently? Yes, of course. But, that is relevant.
Right. So I guess we're kind of going off script here a little bit, but that was the argument that was mounted by the defense in this case, right? The fact that after discharge, there was a reported another argument with the boyfriend. So if that second argument didn't take place, would it have ultimately resulted in the same outcome? It's impossible to say. And I think that's what makes emergency psychiatry so difficult. Logan, would you agree with the statement that emergency psychiatry is the hardest aspect of psychiatry in terms of the liability that we face?
Yeah, I guess maybe. At least it's actually, you're probably going to see the most amount of cases, right? At the end of the day, there's so much. How much of emergency room is mental health relevant? It's like, I wish I had the numbers in front of me, but man, it feels like 30% of those beds. It always kind of depends on the time of day. At 9 a.m. on a Tuesday, you don't see that many mental health cases. But man, it seems like at 2 a.m. on a Friday night when it's cold outside, there's a lot of mental health issues in that emergency room. It's definitely difficult. I think that there's a lot of extreme difficult situations. What about if this was a pediatric case kind of thing, like a 12-year-old, or I'm very interested in like palliative care, and also, however you want to call it, but like physician-assisted suicide. How difficult could maybe the ethics and liability of some of those cases might be as well. But I think that these are very common issues that, we make this podcast, it seems like for a lot of mental health workers. How many of us have seen similar cases to this? I think what's very, very interesting and what I was surprised about by this case is, now we don't know the exact settlement offers. It says that they were confidentially settled in this case, the plaintiffs and the defense. But what the plaintiffs offered was the social worker would have to pay $475,000 and the EM physician only $45,000.
What's up with that, Logan?
I was absolutely shocked.
That was the most shocking part.
And I was like, wait. I always thought in my head, I always thought the physician would always be sued for such a higher amount. That to me was actually one of the most shocking components of this.
Do you feel like the social worker who interviewed the patient is more liable than the ED physician?
I would concur. Just because, look, we've worked with a lot of ED physicians. Sometimes, they do have time to maybe call a collateral, call that ex-boyfriend. But, when a gunshot wound rolls in, when a patient is going into cardiac arrest, that is not a situation that I feel qualified to intervene on. That is obviously not a situation that the social worker could intervene on at all, right? Versus us, we have us meaning mental health workers, we have an extreme amount of expertise, experience dealing with these kind of situations. We are the experts that should know with absolute certainty that you can't take someone's story at face value. You have to get other pieces of information. We've been trained on this, that this is absolutely something that you have to do. And another piece of information, if you can't get that collateral information, is observation. At the end of the day, there's a lot of ethics involved here, right? But holding someone against their will, I get it, even if they weren't necessarily committed to into the hospital, but holding them for observation, seeing if they could handle that distress tolerance and not engage in any suicidal activity actually gives you a lot of information that this person can tolerate potentially a safe discharge. And that's what I was talking about earlier. I wonder how much of this was the business side of the emergency room really pressuring potentially that social worker to make a decision as fast as possible.
Right. But I would argue that if this social worker, who presumably is somebody who's doing these kind of interviews on a regular basis, that person absolutely needs to know that you can never take just a single person's account at face value. You need to be able to verify that with other sources, in this case, the boyfriend. And you spoke about the expertise needed to handle cases like this. And Logan, I think you're absolutely correct because, look, some cases are so straightforward, right? Somebody comes in, they say they're suicidal, they have a plan. Yeah, of course. You want to send them to an inpatient facility, whether that's on a voluntary basis or involuntary patients. But oftentimes there's so much nuance. And, for example, when we're looking at a case like this is somebody who was arguing in a vehicle with her boyfriend, and she said she wanted to jump out of a car, right? So here, let me throw a wrench in the case. What if this is somebody who has a history, anytime that they get into an argument, anytime they're frustrated, that they make statements like that? They can get a little frustrated and they, people make these kind of statements all the time. I'm going to kill you, right? Out of frustration. They don't really mean it. So what if this is somebody who's making these kind of statements all the time? They get in trouble by their parents and they're like, I'm going to go cut myself. They, go through a breakup and they're like, okay, I don't want to live anymore. Right? Is this really truly a suicidal, a statement made with suicidal intent? At face value, yes, but that's where the history comes in, right? If this is somebody who's saying that all the time, you still have to be careful. You still have to approach it with a level of caution, but at the same time, you have to remember that the option, especially if they don't want to go inpatient, what you're essentially going to do is, the only options that you have is really to discharge them, to give them what they want, or you have to commit them involuntarily. And that's a whole nother bag of really controversial and really complicated issue, right? Because involuntary commitment essentially requires you being involved in taking another person's civil liberties away. So what is the right call here? That's a decision that emergency psychiatrists are faced with all the time. And look, the reality is we've worked with many different physicians in this setting, and some people lean more towards the side of they care more about the liability that we may potentially face if things go sour, right? So they're like, even anything remotely difficult or anything with even an element of nuance, their immediate reaction is like, hey, let's just commit this patient. Mm-hmm. But there's also other people who are much more focused on patient autonomy. They're much more focused on the individual rights of the patient, and they're more mindful of the fact that, yes, it would even be an easier choice to just screen them for potential involuntary commitment, but at the same time, you understand what that really means. You understand that you're involved in advocating that person's civil rights gets taken away. And essentially, they're like being put in temporary mental health jail, right? Mm-hmm. I think what people have to understand is whenever somebody gets committed involuntarily, like what happens? They're not allowed to have their phones anymore, right? Everything gets taken away from them, all their personal belongings. They have to be put on a one-to-one. Essentially, somebody has to be there watching them all the time because they're considered a suicide risk. So it's a very uncomfortable position for somebody to be in, and I don't think it's something that it shouldn't be something that's taken lightly. Mm-hmm.
Yeah, and I do also think what's relevant here is, I also think it's an impossible burden to put on, psychiatrists and of course social workers. So really any mental health worker that's in this kind of situation. How can we predict the future? These are human beings who are going to make their own decisions. We can make educated guesses at the end of the day, but we are never going to bat 100%, right? We cannot be perfect. We are going to discharge patients who end up doing something stupid at the end of the day. It's something that I think a lot about. It's something that I obviously want to work my hardest to try to avoid. but I also know that perfection is impossible. And, that's why I just feel so passionate about trying to develop innovative solutions, whether that be through pharmacology. Now we're seeing potentially like ketamine potentially is even maybe a mitigation strategy to reduce suicide ideation in an acute setting like this. Could a drug like that have maybe played a role here? Could maybe an innovative solution like a group program through online modality, like similar to like that Babbel Spanish program, but like these distress tolerance kind of classes that can be offered around the clock that patients can access a lot easier, rather than handing them a piece of paper and saying, hey, here's a bunch of clinics in your area, good luck. Because I just don't think that's good enough. I think that's actually we have to hold ourselves to a higher standard. Is there anything else that you wanted to touch upon on this case, Joon? Any other thoughts that you have?
We need more modalities to help our patients. We're extremely limited on what we can do in the emergency department setting. And as psychiatrists working in that kind of environment, a lot of the times I was in a place where I felt pretty much helpless. I knew that if I discharged somebody, that most likely they would be coming right back. And that's not the fault of the patient. I think a lot of that has to do with the lack of outpatient support that's available when it comes to mental health, and especially for patients dealing with suicidal ideation. I wish it was different, and I hope change is coming. I hope change is coming soon. Am I hopeful? To a certain degree, but as we all know, with things like this, change comes extremely slow. One last question I want to ask you, Logan, before we kind of wrap up this episode. If you were involved in this case, what other pieces of information would be important to you in making the decision for disposition?
Right. Great question. We get this question a lot on all of our standardized tests and everything. Number one risk factor for potential future suicide attempts is past suicide attempts. Was this her first activity with suicide ideation? Had she ever attempted suicide before? Because that right there is this person who had attempted suicide 10 times in the past. That right there, raises my red flags immediately. And I also was very surprised, maybe it's because they didn't gather, all the necessary collateral information. It said this patient tried to jump out of the moving vehicle, but it was very confusing here. Was this a moving vehicle on the highway going 70 miles an hour? Was this a moving vehicle in a parking lot going 5 miles an hour? Because there's a big difference there. One I would strongly say is a suicide attempt. One I would say is, it's risky, but probably not going to die, right? So I think there's big differences here. Kind of like we were talking about earlier, drugs, you can't necessarily, at least in the state of New Jersey, commit someone based on drug use. One thing I also thought that was kind of bothersome to me is, maybe it was listed in a different area, but I don't know where this case happened. And it kept saying, oh, well, this person could not have been involuntarily committed. But it's like, okay, but involuntary commitment laws change state to state. Some states err more on the side of patient rights, actually. Some states actually err more on the side of giving physicians more power to involuntarily commit someone that makes them feel nervous. So I actually don't feel strongly that this person necessarily, with 100% certainty, was not involuntarily committed. I know I used a double negative there. I'm sorry. But like in certain states, this person, I think, maybe could have been held, at least for observation, much longer.
Right. And I think it also depends on which psychiatrist or physician saw this patient, because unfortunately there is an element of subjectivity when it comes to evaluating these cases. And sometimes it comes down to how much risk tolerance that provider is willing to undertake. So basically, they're weighing patient autonomy versus what kind of potential liability I could face if, on the minimal chance that something does go wrong, right? And that's always the fine line we're trying to walk, especially given the fact that it is, like you said earlier, a very litigious society. And I just want to point out that the fact that she jumped out of a moving vehicle, the patient in this case, that was never communicated by the EMS personnel to the ED physician. And that was one of the things that was brought up by the defense. Because I think if I was ever involved in a case where, and I think this is for everybody, right? It's just logical. If somebody says they're going to jump out of a moving car versus if somebody actually tries to do it, like they're grabbing at the door, versus if somebody actually successfully dislodge themselves from the moving vehicle, those are very different scenarios, right? And the level of seriousness is vastly different from somebody who actually makes it out of that moving vehicle and somebody who's just saying that they're going to do it.
Right. So, I mean, I guess the best words of advice, from this case that, I've taken away that I would advise all my colleagues who work in this space is, call collateral information. What we've been advised, and I am not a lawyer, so do not take my lawyer advice, but what I've been told from a lawyer, get your own lawyer, is even if a patient says, I do not give you permission to speak to that person, that means you cannot tell that person information about them. But you can gather information and just say, is there anything relevant that you want to tell me about this case? So even in my opinion, and once again, I am not a lawyer, but if that person said, I don't want you to talk to my ex-boyfriend, screw that piece of crap, the medical care team still could have reached out to that person and said, hey, look, I cannot tell you about her clinical state. I cannot tell you anything about her clinical care, where she is or anything. But can you tell me about the events that led to you calling 911?
And what is the reason that procedure is in place? It's because collateral information is absolutely 1000% necessary to make a final decision on whether a patient can be discharged, whether a patient needs to go to the hospital on a voluntary basis or even on an involuntary basis. So again, that just boggles my mind that in this case, collateral was not contacted. I feel like that's, emergency psychiatry 101. Even an intern, even a medical student would be able to have that level of insight, knowing that you have to verify that information. So my final verdict on this, I think the social worker was negligible. They definitely should have contacted collateral. And, I understand the ED physician, they're not really experts in this. They don't have the same kind of skill set in doing an in-depth risk assessment to this degree. And to the ED physician's credit, they did bring in a social worker who presumably was specialized in this kind of work. So I think absolutely the social worker, the onus was on them to contact collateral. And in this case, they didn't. Had they reached out to collateral and had they found out that the person actually tried to jump out of this moving vehicle at the time, I think the result would have been completely different, and perhaps a life could have been saved.
I mean, I'm going to have to partially disagree with you there. I was actually rather surprised that the EM physician was only, once again, we don't know the confidential amounts that they did settle for, but 10 times less than the social worker. It even highlighted in this article, there are rural parts of this country where EM physicians do not have a social worker able to do this. They do not have a psychiatrist on call. They are doing this. So EM physicians should at least be trained how to do this. And remember, as mental health people, we serve as consultants to the primary physician. The primary physician, when that person is in the emergency room, is not the psychiatrist. It is the EM physician. And we provide our consulting opinion, and the primary physician can either agree or disagree with our consulting opinion. At the end of the day, I do not discharge people directly from the emergency room. The EM physician does. The EM physician hits that discharge button. They can either agree or disagree. Most of the time, of course, they agree with my recommendation. But I have seen cases where EM physicians said, no, I think this is a dumb decision. And I actually have seen one case in particular where the EM physician, I was very proud of them, held the person because they did not feel safe discharging this person. So I think that the EM person, the EM physician, should be equally as liable as that social worker. They have a higher skill set of training. They have gone, they know the workings of the emergency room. They certainly have seen a lot of psychiatric cases in the emergency room. They should be liable too.
I agree, but we'll also agree to disagree.
Agree to disagree. All right, good episode.
And we'll leave it
this
there.
was tough. Tough case. Hey, if you enjoyed this topic, one of our first episodes, I think it was episode 1 or 2.
Two.
Was it 1? 2?
I think 2.
Ethics of Emergency Room, one of our most downloaded podcast episodes. Audio only, though. Sorry, folks. But tune into that one if you like it. Check out the rest of the work we've done. You can find all of us on social media and all that jazz. Thanks for tuning in.
Follow the show, please. Thanks for tuning in, everybody. See you next time.
Cheers.